So I'm Dr. Ganesh Kumar. I head the Department of Cardiology at Dr. L.H. Hiranandani Hospital, Mumbai. And with me are two very senior cardiologists. Next to me is Dr. Harikrishnan from Sri Chitra. He's a professor from Sri Chitra, Department of Cardiology. And Dr. Kirti Punamiya from Breach Candy Hospital, Mumbai. So today's discussion would revolve around revascularization in heart failure patients. It's a very important topic because this is one thing that makes a difference in the longevity of the patient. As you know, the burden of heart failure globally is huge, and in India we are catching up with global statistics. It not only impacts the work hours or the man force as far as employment is concerned, it actually translates into a gross economic burden on the society. So revascularization is one thing that that needs to be addressed so as to improve not only quality of life but to reduce the economic burden. So let me start with Dr. Harikrishnan. In your institute, what is the percentage of heart failure patients? The fact that you're doing a registry now in Kerala, what do you think is the percentage of patients whom you can actually offer revascularization?
In the Trivandrum heart failure registry which we did, coronary artery disease contributed to 72% of the total heart failure burden. Similarly, the inter-CHF Indian arm of the inter-CHF also showed significantly around more than 60% of patients with ischemic heart disease. So coronary artery disease is the major contributor to heart failure in our country also compared to the similar to the West. So in our hospital, because we are a tertiary care hospital catering to valve disease also, still around 55 to 60% of the patients with coronary artery disease are coming to our admitted as heart failure. Out of them, probably revascularization in two modalities, CABG and PCI, probably around out of the 60%, probably if you take around 30% of them may be going for revascularization.
Okay. So basically we are seeing a trend where we believe that the coronary artery disease is overtaking other etiologies as far as heart failure is concerned, and we are catching the trend of the Western countries.
Of course.
Okay. So what do you feel is the rationale of revascularizing these patients?
Yeah. We know that ischemic cardiomyopathy or heart failure with reduced ejection fraction due to ischemia is a dynamic disease because we have the viable myocardium due to hibernating myocardium, because two types of myocardium is there. The one is the scarred myocardium where there is no benefit in revascularization. The second is the hibernating and the stunned myocardium where when you revascularize the LV function improves. So in significant number of patients it was found that there is a significant percentage of patients who improve the LV function on revascularization because the viable myocardium is getting perfused and it improves. So there is a significant percentage who improves after revascularization. So that is the basis of even eckinetic and hypokinetic segments definitely improve on revascularization. That is what we have seen. Even though we don't have any revascularization studies, this is what we are clinically seeing.
Right. So to you, Dr. Punamiya, how do you think you will evaluate your patients and demonstrate hibernating myocardium or viable myocardium? So
I know. Thank you, Ganesh, for this. When you look at it, when we started off, we thought of this as a great concept, and the concept was hinged around the fact that it's hibernating, and if it is hibernating, revascularization is going to improve that, and therefore it is going to surrogately improve LV function and outcomes. But as we look at some of our current trials, it's becoming more evident that the role of viability, using viability measures which were probably studied in the years 2010 and 2011 by way of the STITCH trial, don't seem to pan out in terms of deciding who's going to come out favorable with the intervention. So in this day and age, will I kind of assess a patient for viability to decide revascularization for patient? Probably not. Now this may be limited because of the methods used to assess viability, and those were dopamine stress echo and SPECT images in those patients. Very few people started having cardiac MRIs in those trials. But cardiac MRI is the emerging field, and I think we'll have to re-look at some of this data using cardiac MRI and its ability to recognize this, to see if it is going to be able to decipher patients which might benefit from your revascularization. So at this present time, to answer your question, after looking at the 10-year outcome trials, which is just published in the table issue of New England Journal at this present time, I think that I have to rethink whether I need to study viability at all. The question is, it still doesn't answer whether you need to look at reversibility, and the question would be how to look at reversibility. Because we know that revascularization helps in those people who have reversible ischemia and those who have a large area of reversibility, and so revascularization will neutralize that and thereby improve outcomes.
So today you are actually going to revascularize a patient based on viability, or you won't look at viability?
I think if there is coronary artery disease which is significant, I think the data tells me that if it is significant, you need to offer them revascularization, irrespective of viability. Viability is not going to be one of those things which you need to put into factors to decide whether the patient needs or doesn't need a revascularization. On the other hand, let me say that when you demonstrate viability by any method that you can, these patients who have viable myocardium end up having better left ventricles, and they do better over a long term, whether you give them revascularization or whether you continue medical therapy. So we are in a state of flux at this present time, and I think that we would have to find another method to look at whether a particular patient is, though when he has coronary artery disease, whether he is going to be a candidate for revascularization or not. And I think this will hinge upon the completeness of the revascularization. So the therapy that is going to stand out in this is a therapy that will effectively offer the patient complete revascularization without increasing the risk of the procedure.
Dr. Harikrishnan, so taking from Kirti's comment on looking at viability or not looking at it, how will you take this when it comes to explaining to the patient or the family about the outcomes of revascularization without doing a viability? I mean, do you actually follow the viability evaluation, or would you, because as per guidelines it's still 2B without demonstrating viability?
So I don't routinely send patients for viability. If we take different parameters, we take an echo and see whether the thickness is preserved, we'll see the ECG where the R waves are preserved, and see the clinical situation, and occasionally we do an LV angiogram also in some patients and see how the LV, we have that, all these parameters and the clinical situation whether the patient has angina, whether we will be able to do a full revascularization or the complete revascularization, all these points will be considered before. Viability is not the only thing which we do. I think all of us agree on that.
Yes.
So that is how. So what I explain to the patient is that you have LV dysfunction. So in some of the patients who have LV dysfunction have recoverable myocardium, there are certain tests to do that, to assess that. Probably we send our patients for MR. And if you have a very good chance of recovery according to the result, we will be pushing you for revascularization rather than keeping you on medical treatment, because revascularization has found to improve your long-term outcome.
How does your decision change when there are comorbidities like bad diabetes, peripheral vascular disease? So do you take these factors into?
Of course. We should consider comorbidity. That is what we say in, we have seen in the ESC guidelines, what they say, comorbidities, I think the heart team should be there. Heart team approach, that is what they recommend, because patients will have comorbidities, patient will have, for example, patient will have mitral regurgitation, patient will have an LV aneurysm, patient may not, because the two modalities of revascularization, PCI and CABG, some CTO we may not be able to open. So we have to discuss all these things with the patient that we are going to do an incomplete revascularization by PCI, but if you go for CABG, you will have a complete revascularization. So a heart team approach may be I think that is a good idea. It's a good idea. I think the ESC guidelines say very clearly that a heart team approach should be there in recommending revascularization.
Everybody chips in. The final aim is a complete revascularization. So coming to complete revascularization, and recently the published Korean heart failure registry shows a clear-cut advantage of bypass at the end of 4 years of reducing all cause mortality by 40%. So Kirti, which modality of, we know that PCI is not enlisted either in the ESC or the ACC guidelines as the favored revascularization strategy for heart failure patients. So what do you feel, where do we stand as far as PCI versus CABG is concerned as a modality of revascularization?
So I think when you look at the European guidelines, you're right. I mean, the European guidelines actually favor bypass as the first choice of therapy in patients with heart failure and coronary artery disease. But if you look at the American guidelines, they've been a little more liberal, and they've allowed the use of angioplasty in a suitable anatomy. So if an operator would think, or a team would think, that angioplasty can safely be done in a particular anatomy suitable for angioplasty in heart failure, then I think that is going to pan out as well. The problem with some of this is that we lack data which is contemporary. Now, we look at all these trials which compared CABG to medical therapy in the past era. When you look at where does the data come for angioplasty, comparing itself to bypass surgery as a form of revascularization and heart failure as a subset, then there's very scattered and very little data, very widely spread. I mean, even if you looked at major revascularization trials which compared CABG and PTCA, you look at the Syntex trial, just 2% of the Syntex population actually had heart failure, LV functions less than 40%. The Freedom trial, again, which did that, very few people. So we have very little to compare from with the current ones. If you look at the older ones, you can see that CABG has outperformed medical therapy for sure. CABG or a good angioplasty will outperform medical therapy at this present time in the treatment of heart failure if you look at hard endpoints. The question is, in a given patient, how do you decide a patient is going to have angioplasty or bypass surgery? I think each center would have to decide their abilities in terms of how well and how safe can they tackle these very complex patients and together with a very complex lesion. And I have a feeling that operator expertise and center expertise will major play in terms of what they decide they're capable to do in that center. But I think the essence of it is going to be deciding who can do a complete job. Can the surgeon do a complete job, or is it going to be the interventionalist who can do a complete job? Fortunately for the surgeon, it has always fallen in favor because it's easy to graft one extra vessel when you've opened up a chest. It's not the same for an interventionist. Every vessel you are going to introduce, your stent in, or you're trying to revascularize, you're going to impose a certain element of risk. And we saw that in the Syntex trial. As you start indiscriminately doing angioplasty just to be complete, the complexity gets worse and your MACE rates go up.
Right.
So, on one hand, you want to be complete. On the other hand, when you're trying to chase completeness based on anatomy, you are going to get more trouble. So then how do you decide what is complete? So we looked at functional studies, but how relevant are the functional studies in heart failure group of patients is another question. So I think we are in a corner right now.
So with the availability of various support devices, do you think the next few years we'll see a change and tilt towards PCI?
So that is very interesting that you asked this question. And I mean, if you look at the support devices, I mean, which are relevant to us in the cath lab, I think the most important of these devices is the left ventricular devices which decompress the left ventricle, namely the left ventricular support systems like the Impella and the group of and that group of devices. The data is very small.
Yes.
If you look at the Protect 1, the Protect and the Protect 2 trial, you see that there is no outcomes data which supports the use of these devices in high-risk PCI2. But if you go and look at 2013 article from some of the groups, I mean, they have looked at intra-aortic balloon pump, the BCIS1 trial, if you recall. This was an UK-based trial, and they found that just using the intra-aortic balloon pump in high-risk PCI improved their 30-day mortality. Kind of when you look at that trial, it's kind of surprising. It was published in Circulation, but how does something like that, which has very little impact on cardiac output, influence the mortality so easily? All these are questions. I think we'll have to study these patients better, and I think good angioplasty, good imaging, the reduced contrast use is going to be key. And one thing that shows me promise is by using devices which are going to support cardiac output maximally, there is some evidence to show that they reduce acute renal injury. And if they can reduce acute renal injury, then they will reduce immediate morbidity and mortality in this group of patients. So I'm hopeful.
So can I summarize from the inputs that I received from both of you that today viability is may not be the key. If you are able to revascularize, try revascularizing all heart failure patients. The modality of revascularization based on the guidelines and the trials that are available still CABG scores over PCI as far as you can mitigate the risk of a bypass surgery versus the long-term outcomes are good, provided you get away with the risk of a surgery. And wherever there is a 1 vessel or a 2 vessel and even 3 vessel disease where you can think that you can give a complete revascularization, PCI should not be ignored. It can be looked into it with the help of or without the help of assist devices. The key is complete revascularization. Am I correct?
Yeah, absolutely.
I mean, both of you agree on that?
So I think you actually said it, and though we think that CABG is the favored option, how many times is your surgeon going to come and say that, okay, this particular case is a little too risky for me to handle?
Yeah.
So, I mean, when you ask surgeons, they say, what is a patient that you would refuse? And my surgeons will message me and say, well, if your patient can have a haircut, he is going to be able to be having a bypass without a problem. But that's not really true in clinical practice. We see patients with chronic obstructive airways disease, with those renal failures which are borderline, which are likely to get onto dialysis, patients with recent sepsis, with cardiorenal syndromes, with recent strokes, and there is that frail elderly man who does not fit into any clinical trial, but he definitely comes into your EMS very often with heart failure and ischemic heart disease. How do you make choices in them? And your surgeon doesn't want to touch them. So I think there will have to be a skill set developed in every region to be able to handle this group of patients with alternative revascularization modalities.
Especially when mitral valve surgery, mitral valve repair, we should always aim for mitral valve repair, and we should have expertise, refer patients to areas where they have expertise in repairing the valve rather than getting into a replacement and producing more complexities to the issue.
Right. So, would you like to close this session by just putting some light on what's happening with your registry that you are doing?
Yeah, we are doing the National Heart Failure Registry under the aegis of ICMR. We are planning to recruit 10,000 patients across 52 centers across 25 states. And we are what we are aiming is to have a nationally representative data on heart failure, which we don't have. We have only Trivandrum Heart Failure Registry, Kerala Registry, and localized data only. So this probably will get us into get us data which is representative of the whole country, which will give more answers to our questions.
Are you going to capture revascularization modality in that?
Yeah, of course.
Okay.
We are going to revascularize.
That's going to be good.
Are you looking at things that might favor or improve your outcomes in terms of predictors?
Yeah, we are looking at predictors like what are the predictors of mortality, like whether they are getting guideline directed therapy. Even medical therapy improves the outcome of our ischemic cardiomyopathy patient. That we have to
absolutely.
Only 27% in our group received the guideline directed therapy. So we are talking about hibernating myocardium. We are not giving these are not costly drugs also.
Yes,
so
absolutely.
Right.
So I think we'll wind off this session. Thank you so much much to both Dr. Harikrishnan and Dr. Kirti Punamiya.
Thank you, Ganesh.
Thank you.
Thank you.
Thank you.